Welcome to this explainer. If you are gearing up for your MD pharmacology exams and need a rock-solid, high-yield breakdown of drug excretion, clearance, and therapeutic drug monitoring, well, you've landed in the exact right spot. We're skipping the textbook fluff today. We're getting straight to the core principles you need to actually master these concepts and crush those clinical applications.
Let's take a quick look at the game plan. We're charting some serious high-yield territory, starting with basic routes of elimination and renal excretion, then we'll hit the essential math of clearance, and finally, we'll test all this against real-world 2026 clinical updates. Let's get right into it.
Section 1. Routes of drug elimination. We start at the absolute foundation.
Okay, pay attention because this is a classic five-a trap. Elimination is not just excretion. Think of elimination as the big umbrella. It's the irreversible loss of a drug from the body, and it's actually a two-part tag team. First, you've got metabolism. Why? Because highly lipophilic drugs, the fat-soluble ones, they just bounce right back into your bloodstream. Metabolism has to step in and decrease that lipid solubility, turning them into polar products so the kidneys can actually do their job and flush them out.
So, where do these drugs actually exit? The kidneys are definitely doing the heavy lifting here, but you absolutely cannot ignore the alternative routes. A great little mental checklist for your exams is to track the fluids: urine, bile, breath, and minor fluids. The hepatobiliary system uses bile to dump drugs into the feces. Your lungs actually exhale highly volatile agents like anesthetics, and this is absolutely crucial. Minor routes like breast milk might seem quantitatively tiny, but they are incredibly important clinically when you're dealing with a nursing infant.
Moving on to Section 2, renal excretion mechanisms. Time to look closer at our primary filtration system. Lock this definition into your brain because you will absolutely be asked to define it. Renal clearance is the volume of plasma that is completely cleared of a substance by the kidneys per unit of time. It is the core mathematical metric we use to evaluate renal function in pharmacology. So how does a drug actually end up in the urine? It's got to navigate three distinct stages. First up, glomerular filtration. The high-yield exam point to remember here is that plasma albumin is impermeant. That means only the free, unbound drug actually gets filtered. Next, we have active tubular secretion, where carrier molecules actively pump drugs into the tubular lumen. And finally, passive reabsorption. This is where those lipid-soluble drugs we talked about earlier will just passively diffuse right back into the blood as water gets reabsorbed. Now, because that active secretion stage relies on non-selective carriers, drugs will actually compete for a spot on the pump. This leads to some classic drug interactions. Probenecid is a famous example. It was literally developed to block the secretion of penicillin, keeping it circulating in the blood for much longer. But it's a double-edged sword, right? Take indomethacin. It can drastically reduce the clearance of methotrexate, which massively spikes the risk of severe, life-threatening toxicity. You definitely want to remember that one. Section 3. Ion trapping and urine pH. Let's see how changing the pH changes the entire game.
This concept right here, the pH partition principle, is a literal lifesaver in emergency overdose situations. Let's say a patient comes in with salicylate or aspirin poisoning. Aspirin is a weak acid. If you deliberately alkalinize their urine using sodium bicarbonate, you massively accelerate the excretion of that acid. Why? Because that alkaline environment favors the charged, ionized form of the drug. It basically traps it in the urine so it absolutely cannot diffuse back into the blood. The exact same logic applies in reverse. Acidifying the urine traps weak bases. It's an incredibly elegant clinical trick.
All right, Section 4. Biliary excretion. Let's shift our focus over to the liver. Check out this fascinating physiological loop. Enterohepatic circulation. So the liver secretes hydrophilic drug conjugates, like glucuronides, straight into the bile. This bile dumps into the intestine. But here's the catch. Enzymes in the gut hydrolyze that conjugate, which frees the active drug all over again. And what happens? That free drug gets reabsorbed right back into the bloodstream. It creates this crazy reservoir effect, and it perfectly explains why drugs like morphine and digitoxin just linger and have such a prolonged duration of action in the body. Section 5. Drug clearance fundamentals. Time to put some solid math to all these physiological concepts. This equation right here, this is your master key. Total clearance relates the rate of drug elimination to the drug's plasma concentration, or CP. Simply put, total clearance is the sum of renal, metabolic, and all other clearance rates. Understanding this formula is absolutely critical for figuring out how we maintain steady, safe therapeutic drug levels in our patients. Building directly on clearance, we have the elimination half-life. It's directly proportional to a drug's volume of distribution and inversely proportional to clearance. But here is the golden rule you need to memorize for steady states. During continuous administration, it takes roughly 3 to 5 half-lives to actually reach your target steady-state concentration. That means you simply cannot instantly reach steady state just by starting someone on a standard maintenance dose. It takes time. And obviously, a longer half-life means that drug accumulation takes even longer.
But wait, what if waiting 3 to 5 days is literally a matter of life and death? Well, we bypass the wait entirely by giving a loading dose. Notice how this formula relies entirely on the volume of distribution, not clearance. That is a huge clinical pearl. It means that even if your patient is in severe renal failure, your initial loading dose usually stays exactly the same just to fill the systemic tank, so to speak. It's the subsequent maintenance dose that you're going to have to drastically adjust.
Section 6. Clinical Applications. Let's tie all these first principles into the real world and check out some vital 2026 updates.
Digoxin is the ultimate case study for therapeutic drug monitoring, or TDM. We rely on TDM for drugs with a super narrow therapeutic index, and for digoxin, that safe window is just 1 to 2.6 nanomoles per liter. It's tiny. We measure trough levels right before the next dose to ensure the drug isn't quietly accumulating. Now remember, digoxin is excreted renally and has a massive 36-hour half-life. If your patient goes into renal failure, that half-life extends dramatically. If you don't strictly reduce their dose, you are practically guaranteeing severe toxicity.
Now, shifting gears and applying these exact same clearance concepts to the 2026 GINA asthma guidelines, we're seeing a massive paradigm shift. For years, the standard was an over-reliance on SABAs, short-acting beta agonists for quick relief, but that led to dangerous tissue accumulation. The new 2026 standard completely flips the script. We now treat asthma primarily as an inflammatory disease, mandating anti-inflammatory reliever therapy, specifically ICS formoterol, to prevent exacerbations rather than just helplessly reacting to them.
So, why the big shift? Let's break down the pharmacokinetics of SABA toxicity. When a patient overuses a SABA, it causes extreme beta-2 stimulation. This heavily drives up glycolysis in the body. Eventually, your normal clearance mechanisms just get totally overwhelmed, leading to a massive accumulation of lactate and, boom, metabolic acidosis. And here's the really scary part. The patient starts breathing fast. They become tachypneic from the acidosis. This tricks the provider into thinking it's a worsening asthma attack, so they give even more SABA. It is a vicious, potentially lethal cycle of impaired clearance.
And speaking of respiratory updates, aggressive oxygen administration is no longer the default standard either. You should now only administer oxygen to these patients if their saturations drop strictly below 92%. Why? Because blasting them with unnecessary high-flow oxygen can actually worsen ventilation-perfusion mismatch and dangerously alter their systemic metabolic clearance states.
Finally, let's take a super quick look at some 2026 oncology approvals because they are leveraging entirely new clearance and distribution mechanisms. For instance, datopotamab deruxtecan is a precision antibody drug conjugate. It completely bypasses traditional systemic clearance to deliver highly targeted toxicity right to the tumor. Then you have therapies like Tecentriq SC, which alters absorption and distribution kinetics entirely by being a rapid, 7-minute injectable. It's wild how fast this field is moving. Which leaves us with this final thought. As incredible breakthroughs like precision-targeted therapies completely redefine modern medicine, how will our foundational mathematical models of clearance and half-life need to evolve to keep pace? The drugs are changing, for sure, but the underlying first principles of pharmacokinetics remain exactly the same. Keep reviewing these clearance concepts, master your TDM protocols, and they will absolutely be your bedrock, both for acing those pharmacology exams and in your future clinical practice.